Hi, and welcome to this recorded presentation. My name is Maxine Kuczawski, a researcher at the University of Sheffield and the lead on this study, identifying patient characteristics associated with long length of hospital stay and the potential use of existing scoring tools to identify susceptible patients to long length of stay. Particularly for older patients, the days of a simple, straightforward diagnosis, treatment, and then discharge are rare. With advancing age comes more comorbidity and increasing complexity, which an admission to hospital can result in a longer length of stay, further exacerbating patients' mental and physical health. Patients that experience long length of stay are at risk of falls, acquiring infections, and their ability to undertake tasks such as dressing can reduce. From a service perspective, long length of stays in hospital are resource intensive and come with a significant financial burden. This issue was brought into the national spotlight in June 2018 when the UK government released the Guide to Reducing Long Hospital Stays, a programme aiming to improve patient care and experience by discharging from hospital without unnecessary delay and reducing long length of stays. Alongside this programme, the Secretary of State announced a target of reducing these long length of stays by 40% by March 2020. Understanding which patients experience long length of stay not only provides an overview of the epidemiology of this cohort, but also helps to identify potential patient characteristics and identify cohorts of patients for targeting with interventions to reduce long length of stay. This rapid review aimed to identify up-to-date literature in relation to long length of stay in hospital, identify patient characteristics associated with long length of stay, and assess existing scoring tools that may be used to predict which patients may be susceptible to long length of stay. This technique was used as it allows modifications to standard systematic review methods in the interest of speed, which was important for the stakeholders in this project. A keyword-based literature search was undertaken in 5 bibliographic databases, supplemented by additional search methods. After initial screening of a select group of papers, it became apparent there was no common definition of long length of stay. The UK government policy refers to a 21-day cut-off. However, this was not reflected in the literature, where often there was no explicit statement of what was considered a long length of stay, or if it was stated, 7 days appeared to be the most used definition. Therefore, the general term length of stay was used as a starting point for the searchers, with restrictions then applied to narrow the focus, such as mesh headings, using the title field only, hospital setting, and searching using variants of the term. Adults in developed countries were included, with maternal, mental health and condition-specific studies excluded. The most commonly used cutoff for long length of stay from the literature, greater than 7 days, was adopted for the outcome, with at least one patient characteristic required. Qualitative intervention studies, reviews or commentaries were excluded, and sources needed to be full text, English language, and published in peer-reviewed journals between 2010 and 2020. Results of the searches produced over 4,500 potential inclusions. 144 records remained after screening of titles and abstracts, and these were further reduced to a final count of 20 studies. The included 20 studies were conducted in 9 countries, with none in the UK. Most were single-centre and most used routine electronic patient data. Patient populations tended to either include all ages or older patients aged 65 years or older, with the latter group the most common. 12 studies explored patient characteristics for long length of stay, and 8 evaluated scoring tools, including emergency department triage systems, National Early Warning Score, NEWS, and those related to frailty, such as brief geriatric assessment tools. All studies included length of stay as an outcome. However, for 13, this was in conjunction with other outcomes like hospital admission, mortality, etc. A number of key findings were identified from the included studies. However, due to variability between studies and their definitions of length of stay, populations, methodologies, the results are complex and not straightforward to interpret. This is likely a reflection of the complexity of the patients, their needs, and the difficulties in trying to recognise these at an early stage in the care pathway. Firstly, studies including patients of any age explored a broad range of health and social risk factors. Most were associated with long length of stay, with no major predictors identified, although the inclusion of comorbidities was common. Existing scoring tools such as triage and NEWS appeared to be sensitive to predict long length of stay for those patients in the emergency department. Secondly, most of the studies including older patients explore risk factors for long length of stay that were closely associated with frailty, often with a type of geriatric assessment used as the basis. Various combinations of age, gender, history of falls in previous 6 months, living situation, presence of diseases, temporal disorientation or delirium, and polypharmacy were found to be good predictors of long length of stay, with the latter two factors identified as the strongest. Thirdly, 8 different existing scoring tools were used to predict patients likely to experience long length of stay, and an association was found in all studies except one. For each of these scoring tools, as severity of condition or risk increased, the probability of a longer hospital stay increased, suggesting potential use in a clinical setting. Finally, strong associations were found between long length of stay, individual patient characteristics, and combinations of patient characteristics. However, when these characteristics were combined into predictive tools, the prognostic performance of the tools varied considerably between studies, raising concerns about the use of such methodology to prospectively identify long length of stay patients in clinical settings. Strengths and weaknesses existed for both the included studies and the rapid review methodology. Most included studies used hospital administration records, potentially introducing information bias due to the errors in data entry or misinterpretation. Structural or process changes may potentially introduce confounding effects for shorter studies. Here, there were 5, which operated for less than 12 months. Generalizability is a key issue in this rapid review, as most studies were single-site and most were undertaken in Europe, thus making inferences about populations in other locations, such as the UK, difficult. The streamlined methodology enabled an evidence base to be collated in a quick and timely manner, but this meant compromises had to be made in areas such as data extraction, quality appraisal, and narrative synthesis. This may have resulted in potentially missing relevant evidence. Attempts were made to minimise this, along with ensuring clear and transparent methodology was recorded. Thank you.